Hi, my name is Wendy Matthews, and I am the Executive Director here at JHC Hospice. I have only been here for a little over 2 years. I have been in hospice for 17 years. I am not a clinician, and my staff remind me often because I sometimes pretend I am. My background is business development, operations, financial. That's basically my background. So we're very excited. So many of you have decided to join us. We really, our agency is counts so much on our volunteers and what they can bring to the overall picture of what we do for our patients in the field. So this is our hub. This is our offices. No patients are ever here. We see our patients wherever they live. And that can be either a nursing home, any nursing home in the Worcester County territory. Every hospice has a territory that they have to establish for Medicare. Ours is Worcester County. So you can be either in your private home, an assisted living, or a skilled nursing facility. And if you are in a skilled nursing facility, we have to have a contract with that facility. Hospice is a Medicare benefit. Okay, 100% under Medicare and or Mass Health. It is also private insurance. If you're under 65, do not have Medicare. Every single person that has a private insurance has hospice covered at 100%. So what does that mean? A few things. You have to meet criteria for hospice. So there are many different disease processes, and the clinicians will give you more information on that. But COPD, for example, is a disease that you can live with. It's a chronic disease that you can live with for a long time. But significant changes have to occur for a physician, actually two physicians, to say, yes, we now see changes, whether it's multiple infections, multiple hospitalizations. You didn't need oxygen, now you need oxygen. Remember, I'm just talking in layman terms. But two physicians, one that works for us, our medical director, and then the primary care physician, whether it's in the community or they work for the nursing home, says, yes, I agree. The changes that Mrs. Smith has just currently gone through over the last time period looks as if no interventions are occurring, that the trajectory of that disease may or may not take her 6 months from today. So because we can't see into the future, that's how they base it. And they base it on every disease process that we have: congestive heart failure, COPD, cancers, Alzheimer's, dementia. In the late 80s, early 90s, there was a lot of fraud when it came to Alzheimer's, dementia in particular, because patients weren't actually meeting criteria. Those are a little bit more difficult because, again, you can have a very healthy body and live with dementia, sadly, and Alzheimer's for a long period of time. But significant changes would happen: multiple infections, falls. You didn't need help with your ADLs, you do now. So there's indicators. So that's the crux of the clinical component. You have to meet criteria for hospice. And because we had so much fraud during that time, we have in place, day one is the day that you were admitted onto hospice. Both physicians, my medical director and another physician, say, yes, that patient meets criteria under that disease prognosis. And then our team comes in, and I'll talk to that in a minute. And then in regards to the fraud, they have put into place that during different time periods, they have to be reassessed, either from our clinicians that presented to our medical director or at particular times an NP. We have 3 nurse practitioners that also work for us. So it's 90 days, there's your 6 months, and then every 30 days after that. Does the patient still meet criteria? With Alzheimer's, think about it. You have a Mrs. Smith who's living in a dementia unit in a nursing home, and she met criteria. And we often talk about this. Well, we definitely talk about this in the beginning with families. She now has this whole extra team of people caring for her, helping her, with her ADLs, with eating. So she may start gaining weight. She may baseline out and may not meet criteria for hospice anymore. ultimately, they succumb to that disease, but we do talk about that. We talk about graduating, and that's usually the disease processes are almost always Alzheimer's and dementia. Really educate families in the beginning as to what that could possibly look like. So you meet criteria for hospice. 2 physicians have signed off on it, and now you have our team. Our team consists of RN case managers, Anne-Marie being one of them. They have a caseload that is a mix of any nursing home patient, assisted living, or home patient, and they're the kind of the equal or above this team. So we also have a medical social worker as well, a clinical social worker. We have our spiritual, because that's the 3 areas that Medicare says that have to be met for end of life. Clinical, spiritual, psychosocial. Those are the 3 areas of death that we have to meet for that patient. And then we also have certified nursing assistants. We also have music therapists, volunteers, like all of you who really play a big part in it. I'm forgetting.
Massage.
And massage therapist.
Pet therapy.
The 3 most important that we have to meet, actually there's 4. There's the psychosocial, clinical, spiritual, and then we also are mandated to have our volunteers be a percentage of seeing our patients. So Medicare pays for our entire team 100%. They also pay for any DME, which is medical equipment. So if Mrs. Smith lives in her private home, she may want a hospital bed. If her skin is eventually breaking down, we may put in a air mattress, oxygen, any medications. We also cover that have to do with the disease process. And then even in a nursing home, the majority of people are living in hospital beds, but they may want other equipment that we would also cover. So that's all covered under the Medicare benefit. We're strictly regulated, but we just recently went through our survey that we're surveyed every 3 years, and we got no deficiencies. So we're very, very proud of that. We are a 5-star hospice, and I'd like to say, because I've worked at a lot of them, that we are the best, definitely, that I've ever seen in Massachusetts, for sure. So I don't want to touch base on what my colleagues are going to be discussing, but overall, it's meeting the needs of people who are end of life. It is our goal to make sure people have what we call a good death. And there's no judgments in that. It is whatever that patient or that family wishes for that to look like. We come in and we do the best we can to make sure people are not in any pain and agitation in all realms of those 3 categories that I've mentioned. And we work with families, and when their loved one passes, we stay with families for 13 months afterwards. We have an entire bereavement program as well. So it's really, a lot of, I think it's changed since COVID, but, it's a taboo subject, but I think more and more families are realizing what a good death looks like. In this country, we celebrate birth. And so that is our goal here. And we work really hard every day to make sure that that's the goal we meet.
Hospice is a philosophy of care, and we focus on your comfort. So there's no more going out to the doctors. There's no chemo, there's no radiation, dialysis, because those are curative reasons. That being said, that doesn't mean that once you come onto hospice, you can't ever go to the hospital. We've had patients who might have had a fall and they needed staples or stitches. They can go. The nurses call ahead. We have a number for UMass that we call. We say, this is a hospice patient, this is what they're coming in for, don't do a full workup, we're gonna do this and we're gonna discharge. We've had times where families have panicked and sent people to the hospital and decided to go more curative. And at that point, they would revoke off their hospice service benefit. And that's not something that we regulate, that is a Medicare insurance regulation. You can't have both. You can't have end-of-life care and be seeking a curative measure to fix a broken hip or whatever it may be. Unfortunately, sometimes those decisions are made and it's not always in the best interest of the patient. We've had 2 outliers that unfortunately, they passed in the hospital, which really wasn't what they wanted. But it happens, and that's okay. And so one of the things that I do when I go to admissions is I always reassure my patients, my families, whoever, we're not written in stone. Anything that you write, we sign today can be changed. But our goal is your comfort, whatever that looks like. Comfort isn't just about what I can give you for medications. Sometimes comfort is food, seeing pictures of loved ones, talking to loved ones, being able to just and we have different equipment, but one of the things we get a lot are called a Broda chair. So it's basically like a recliner on wheels that some of our patients aren't able to go outside because they don't have that proper equipment. And now they can go outside and see the yard they haven't seen in 2 months. So comfort's different for everybody. Yes, there's medications. We have a comfort kit. But that when you sign into hospice, depending on what's going on, we don't necessarily start the comfort meds right away. We base it on what your symptoms are in that time and where the patient is at. I have had patients who, up until the day they passed, refused comfort meds, would not take them. We're just going to meet them where they're at. That is their decision. They have that right to say no. Even if a healthcare proxy is invoked, a patient still has the right to refuse their medication. Sometimes we go into an admission who a patient is their own person, but myself, the social worker, the chaplain might note they might be their own person, but I don't think that they can soundly make safe medical decisions. And so that's kind of what that looks like. Like I was saying, we do have comfort meds. For our home patients, we get them ordered and delivered after we do the admission in a facility. We just write the recommendations, and it is up to the physician of the facility to approve or deny any recommendations we give for any medications or anything like that. But we don't always start them off right away. Like I said, I had one patient recently, would not take any, not even a Tylenol. So, and that's okay. That's okay. I think it's really hard to face our own mortality. And when you absolutely lose control of everything else in your life, being able to say no, I'm not going to take that. That's something that they can still control. Sometimes these people are living in their own homes. They go to a hospital. They're told there's nothing more we can do for you. And then they're sent to a facility. They never go back to their own home again. So not only are they sick, they're now being told they have to sign on to hospice, and they don't get their own home ever again. That's a lot to take in, and there's not much they can control. In a facility, it's not their environment. It's not their control. Meal times are set for you. People come in and give you meds or check your vitals. There's a lot of things that are out of their control. So sometimes it's a lot of just bedside support and education. And I think I love it when my volunteers are there, because sometimes you guys get to see a different side that I might not necessarily see. I always try to build a great relationship with my patients and their families. Not everybody is open to that because they still look at you like, well, you're the nurse. And they look at me like your medication, your blood pressures, or whatever it may be. You're not going in there with any other ulterior motive than to just sit and spend time with them and talk to them and get to know them. So I think that's super important. I've had some really great volunteers build up really great relationships with patients and be able to notice a decline in a patient before I had, say they saw a patient on a Tuesday, but I wasn't seeing the patient until Wednesday. I've gotten messages like, hey, something's changed. Great. So that's really important. And everybody's a little bit different. We do obviously have patients. We have a large amount of patients with Alzheimer's dementia. Some are nonverbal. Some are verbal, but very nonsensical. I do try to caution sometimes, be kind of mindful of if you're watching TV, what is in the background or on the TV. I have one patient right now who absorbs everything she hears on the television. So it can be a little uncomfortable at times. So we're a little cautious of what's playing in the background. As far as like managing their pain with Alzheimer's dementia patients, it can be a little different. If I am in the hospital and they come in, do you have pain? I can say yes or no. I can give them a number. Even my verbal ones, they're not reliable in what they're telling me. So we use kind of two different scales. One is called a pain ad scale, and you kind of go down it and see where you're at, and it gives you a number, and it tells you no pain, mild pain, moderate pain, severe pain. Ideally, we don't want our patients in severe pain, but sometimes you pick up cues. And then we have another one called a FLAC score. But pain ad was made specifically for our Alzheimer's dementia patients. And we go by that. What is presenting as pain sometimes is sometimes agitation or anxiety, and they're just not able to verbalize it. If they have comfort medications already ordered, we talk with the family. This is what we'd like to do. Sometimes families need a little bit more support and education because we do use morphine for primarily most of our patients. Some patients will get Dilaudid, or hydromorphone is the other name for that. And that's just a medical decision based on whether they have, a kidney function, what that is, things like that. But morphine's a really scary word for a lot of people. So in your binders, there is a paper debunking morphine myths, because people think if we give morphine, that's it. They're going to be gone within the next couple hours. And so I honestly, a lot of times with the morphine, I use it more for breathing than pain. Because respirations, the higher your respirations, the more uncomfortable you can be, the higher your heart rate can get, and it just can kind of spiral. So we use it more to control the breathing. It does not stop their breathing. What we use is a concentrated dose. It is not like IV morphine in the hospital. For me, I start my patients, depending on their history, but most of my patients are what we call opiate naive, meaning they don't have a long-standing history of using opiates for chronic pain. So we start at lower dosing. If they notice that they're using like a lot of PRNs or as needed doses of it, then we can schedule it. We always have wiggle room with those medications. Sometimes with our patients who might have been on high scheduled doses of narcotics for cancer-related pain, we start them at a higher dose because we need to manage their symptoms. But a lot of people are just really scared of the word. People assume that, okay, that's it, death is coming. And I get it. And so sometimes it takes a lot of conversations. So on every other Wednesday, we have IDT. We meet as a team.
Interdisciplinary team.
As a team.
IDT.
With our hospice medical director.
So everyone is in here, all the clinicians.
Yeah, it's the whole crew.
Everybody.
For each patient, you go through.
So every single patient will do the admissions first.
Yep.
Go through every single patient.
Yep. Admissions, recertifications, and then, just routine general patients. So, and one of the things that gets looked at is their medication list. A lot of people come on to us, and a majority of our patients are older. We do live in a society where we prescribe meds for everything and then meds for the side effects of those meds and so on and so forth. Comfort, a lot of times, is offloading your pill burden. We've had patients who take 14 pills in the morning and the family's like, they don't want to eat breakfast. I'm like, well, they just ate 4 meals. These pills are huge. And so for me, when I go in and do an admission, I'm going to look at that med list. A majority, not all, but a majority of our families are very willing to make changes immediately of what we call non-essential meds. So a lot of our meds take a longer period of time, or patients don't get true benefits of these meds for months out. Well, we're putting you onto hospice. 2 physicians are saying, should this run its course, your life expectancy would be 6 months or less. What is the benefit of those medications at that point? So we offload a lot of them. But during IDT, our hospice medical director looks through the med list. He will give us recommendations, or I could say to him, hey, so Mr. Smith is on X, Y, and Z, but this is still happening. We're still having these behaviors. He's yelling out, he's biting, he's spitting at people. He'll say, okay, this is what I would do. We also have a pharmacist. And so we all kind of talk as a team. What would these recommendations be? Are there any contraindications for this patient to be on these meds? So our doctor will say, okay, my recommendation is that we put them on Seroquel, 100 milligrams, 3 times a day. So then I'm going to then either go to the facility or to the home. I'm always, before I ever talk to a doctor, I'm going to talk to my patient as well as their family, because they need to be on board. It is their health, it is their life. If everybody says yes, then I'm going to either write a recommendation in the facility, or I'm going to call Mr. Smith's primary care doctor in the community and say, hey, we discussed this at our hospice IDT meeting. This is what our hospice medical director has given for recommendations. That primary is going to tell me one of 3 things: yes, no, or then have him write the order. So,
Makes more sense to have him right there. if you
but
recommend it.
then he would literally be overseeing 100 patients' meds.
Private practice, he's a mass internist. He couldn't do that.
Yeah. You know, and I will say sometimes
And it doesn't look good.
as
We want to partner with.
we want to work
these
with
other
them
doctors.
Partner with their primary.
Yeah,
in taking care of their own patient.
right.
You know,
That's their patients.
some of the patients, their primaries, they've had these primaries for 15, 20, 25 years. They know them. So sometimes it can get a little frustrating if we call and they're like, no. I'm like, okay, well.
And what do you do?
Well, then I just talk to Dr. LaRusso.
And then he
Yeah.
gets
Okay, thanks
mad
for nothing.
And then he calls the primary, and then everybody works it out behind the scenes, and my patient got Seroquel 100 milligrams. So,
Yeah.
and then it's over. You know, but I think it's just so important to make sure the patients and their families are included in all of that. So when I go and talk to them after IDTs, I always say, hey, we had IDT, and I've explained to them what that is, and what we talked about. And, you know, we talked about mom having these issues, and this is what our hospice medical director has recommended. What I have found, in my facilities mostly, is the facility will say, we want to do this, and I've had recently, she's passed now, but I had family say, you need to call hospice, you need to call our nurse and make sure it's okay first. Something as simple as a suppository. So because I think we include them so much and make the decision as a whole, as opposed to coming to them and saying, we're doing this.
Hospice is a very collaborative endeavor, right? And so even though out of all of the mandated core disciplines that are included in hospice care, it is the nurse.
They can't
The
say
nurse
no.
is the only discipline that the patient cannot refuse. But through this mandated interdisciplinary team meeting that must happen, you must discuss every patient a minimum of once every 14 days. When we're having this meeting, the nurse and the medical director are discussing how the patient is looking clinically, but then you have the feedback of what is happening with them psychosocially, what is happening with them spiritually, what are the volunteers reporting that they're seeing with their visits. And so as a team, including with the consultation with the pharmacist, we're like, what can we do to provide the best plan of care to keep our patient comfortable at end of life? And everybody has a say in it. And volunteers are an extra set of eyes and ears on our patients. And as Anne Marie said earlier, you're the one person who's providing care that has nothing to gain, right? You're not prodding at them, you're not asking anything of them. And so you are in a unique position to learn very important feedback that
The
we
moles tell you.
it's very important
exactly.
feedback that we use when we are helping to provide the best care for our patients at end of life. So
Yeah, you guys build a great relationship with them. Before I forget, so there's 4 levels of hospice care. So there's routine, which is the most common one. There is GIP, which is general inpatient level of care. So that's at, like, we go to UMass. So even patients at UMass will call us in because they have patients who have needed continuous medication changes. They're just doing all these things. They're not comfortable. They're not what we call palliated. Just a really nice way of saying comfortable. And so we will admit them to GIP. And it's, you know, I think the longest one was 4 days in the hospital.
Yeah, it could be anywhere from 24 hours to 10 days.
Yeah. We've had a couple GIP patients who were able to get home. We got them actually comfortable and
That's
stable
baseline.
enough to get home. Some people, you know, they pass shortly after coming on to GIP.
And
They're-
they're our patient. They're no longer the hospital
Right.
patient.
Even though they're in the hospital,
With their mortality rate.
and the nurses there are still giving the meds, and the doctors there are still, they then become our patient. Patients are actually seen every day while they're on GIP. That is a requirement that the nurse goes out and sees them every day.
Because you have to assess for acuity. It's a level of care. It's a higher level of care. Does that patient
Still
meet
meet that.
criteria? Is there still something acutely going on with that patient?
It could be something as simple as like they needed like 2 as-needed doses in the last 6 hours. Okay, well, now we have to modify things. So routine patients can be seen anywhere from once a week to every day, depending on the symptoms, what's happening. Are they transitioning to end of life? We also have continuous care. So that's in private homes and or assisted livings, and that's more like a crisis level of care, and I never get the times right.
Okay, 8 hours, 50% of it has to be an RN.
Okay. And you literally are just
Within
sitting
24 hours.
in the home with them because the symptoms are not managed no matter what we're doing, what we're giving. So we are in the home for that set of time.
And the goal with continuous care from and it's a great level of care, is so they don't have to go to the hospital. So we can do everything right there in the home so they can pass at home. So something's acutely going on, but it's a snippet of time. We don't want to transfer them to the hospital.
Right. You know, sometimes our patients will have a crisis. The on-call nurse will go out and make a visit. We're able to give meds. They're okay. But sometimes that's not how it works, and we're having to make constant med changes. They're still going through very uncomfortable situations, and our goal is always to have a good death. You know, so sometimes it requires us being there for a while.
Yeah, so we have to physically be present in the home for 8 hours, and 50% of that has to be the RN. The other 50% can be any other discipline.
Yeah. And then the last one is respite, which I know Christy touched on. So, you know, our patients in the home, mostly in the homes. I don't think I've ever had an assisted living patient.
No, but it can be.
It can be, right, because assisted livings are still considered private homes. But the families may be going on vacation or they just need a break. I had a patient recently who the husband was like once a month. But that took us 1.5 years to get him to agree to that.
It's
We-
caregiver burnout.
Right, we were begging him to do respites. Caregiver burnout is very real. It's very easy. It can happen very quickly. And I think us, as including you guys, we might notice that for our patients' loved ones before they notice it. You know, if you're going and volunteering and sitting with patients and this loved one is just like looking like they haven't slept in days, that's really important to let Sue know or the nurse case manager and just say, hey, like, you know, they were really emotional or just something just seemed off. And if you let us know, then we can follow up and kind of see what's going on. So those are your 4 levels of hospice care. MOLST, which I don't think, you guys have the
I
photocopy.
have a copy of it.
Yeah.
Theirs isn't pink.
So in the homes, you'll see it on the side of the fridge. So in the facility, they cannot be a full code,
No, not anymore.
Not anymore.
Not with our agency.
which is actually a good thing because as a nurse,
Become problematic.
it becomes problematic. If
Can
you,
you just, so
Yep,
most,
so-
most stands for the Massachusetts Medical Orders for
Life-sustaining
Life-Sustaining Treatment, right?
So
And
every state in the country has them. Massachusetts was the first to have it in place. Some of them call them Pulse. And,
every state's got a different name.
think-
It used to just be called a DNR, DNI.
Right.
do not resuscitate.
It's your end of
do
life
not
wishes.
Intubate.
So section A is your cardiopulmonary resuscitation. Either you want CPR or you don't. If you are in a facility, that all has to be a no. There is no CPR, there is no intubation. You are a do not transfer to hospital. We'll go over the back after. We do have some patients who are in private homes who come on as a full code with the goal of 3 months or 6 months.
So
It's like a time frame to have those ongoing discussions with them, what their goals of care are. If you're on hospice and you're focusing on comfort and your heart was to stop, why would you want me to do CPR? And it's a lot of education. As a nurse who worked in an emergency room, I've done CPR many, many times. Sometimes our families and our patients don't understand what CPR actually entails. So, 90-year-old Meme who weighs 76 pounds, I'm going to do more damage to her than anything. So it's just
just getting back to the private home versus nursing home. So that's a philosophy for this agency.
Right.
So if Mrs. Smith lives in a private home and she was just diagnosed with this life-limiting disease, we are not going to say, okay, you must fill out this document, right? They're going to need time. We start from day one having conversations with them as to what that good death looks like. So constant hospitalizations, being intubated, DNR it's not a good death. But a philosophy of ours is that we're gonna meet them right where they are, and we're not gonna force feed them to fill out this document. Nursing homes, we had that philosophy and now we've changed that. It's become very problematic. So this form needs to be filled out. Honestly, the nursing homes are really saying that this form needs to be filled out as well.
Yeah, and it should be. I think it does.
should
It becomes
be
a
in
really
nursing
gray area for nurses if you have a patient who's on hospice in a facility and they go into a cardiac arrest.
Right, it's their license.
Right, it does. One of the things I do explain to people, because what I have seen is people will be attempt resuscitation but do not intubate and ventilate. They go hand in hand. I cannot do one without the other.
So tell them why then.
So, because it's a cardiopulmonary.
Right, 'cause you're doing
So
CPR.
if I'm doing CPR, you have to give the breaths because all I'm doing is pumping your heart for you. So that's the long and short of it. Is all I'm doing is making your heart beat, whether it's going to beat on its own, but you have to give the breath. I don't know what kind of cardiac arrest you're in. You could be in a respiratory arrest. Either way, your heart is stopping. So those go hand in hand.
So people just don't know.
And that's what it is. There's a lot of lack of education, wherever that stemmed from at the time. On the back of this form, you'll see like section F, and that'll just tell you to refer to the front. This is a big one though, is dialysis. They have to be a no to dialysis, no matter where they live. Because that is a curative measure. Artificial.
Someone who has renal disease
Right.
is dying from renal disease, they have to stop the dialysis, which
To
means
qualify. Yeah.
Because that is sustaining them, right? It's the most I've ever seen is 28 days.
I think I had a gentleman when I first started who went 4.5 weeks after stopping dialysis.
Right.
Yeah.
So it's people who are on dialysis realize what that means, but that has to stop. Now, I have had patients in the past who have a diagnosis of metastatic cancer that's spread throughout, metastatic is spread, and they also are on dialysis. We take them on under the cancer, but we have a very serious conversation with them as to what the dialysis looks like, because it's counterintuitive. Those are rare.
And that again is also an education thing because we had a physician refer somebody and he didn't know that his patient had to stop dialysis to come onto hospice.
Right.
He was very shocked by that news.
And I also think for those of you who are aspiring doctors, it's clear that the way we teach Western medicine is do no harm, and we're going to do everything to prolong your life, right? That's what doctors are supposed to do. And so this shift in philosophy that is required by hospice, it's a bit of a contradiction, right? So I think for many families of patients who come onto hospice, that is why it requires so much education, right? Making sure that everybody continues to adhere to this philosophy of comfort and care over treatment and cure, right? That's the distinction.
Artificial nutrition refers to tube feeds. We have taken patients on who are on tube feeds. They'll continue them until they can't. You know,
Because of the absorption.
Yep. Yeah, you know, we've had some patients, I had one myself for a very long time, who, besides the fact that she had dementia and was, you know, bedbound, she did really well until she couldn't. And so as a nurse, that's one of the things that we're assessing at the visits. And we look for different things for absorption.
To what end?
All ends.
Anne Marie, I love when she says that. To what end? Really, to what end
Yeah.
is the artificial nutrition?
Yeah, and we look at benefit versus risk.
Right.
What are we really benefiting? And sometimes people are continuing on artificial nutrition for the family
Yeah.
and not for themselves. And then artificial hydration. So patients can say yes to short-term IV fluid. I always give the examples. We do not introduce IV fluid at the end of life because we are actually pushing against our body's natural process. So I always say to actually, I had a lot of goodbyes today, and one of my families had said to me, I love what you said to me the first day, which is we come into this world on our own, in our own way. We don't leave it any different. Our bodies all kind of go through a process, but how our bodies go through it is different for everybody. But, you know, I do have some patients who are kind of like at a stable point in their disease process. So say they got the norovirus and they weren't able to eat or drink because of that, then okay, yeah, we could probably put in an IV and give a liter of fluid because they're dehydrated because of a virus, as opposed to somebody who is not eating and drinking at end of life, because that is our body's natural, normal process as things slow down. If I go and introduce a bag of fluid, I'm now putting fluid into their body, into their cells that their body can't process, and I'm going to cause a lot of problems, a lot of discomfort. Fluid overload is, you know, and I'm going to flood them, and that's not okay, and that's not comfortable. So again, it goes back into like a lot of education. I mean, honestly, it's pretty much 95% of what I do all day is just provide like education and support, because I can't expect people to know what they don't know. And you go through your whole life being told to go to the doctors every time something's wrong, and now I'm telling you, no, just call us. We're the new 911. You just call us. I have a med that we can fix this or we can do that.
But a lot of the time, like death and dying is new to the family.
It is. And so that's one of the questions that gets asked at admission. What do you know about hospice? You know, what is your experience with hospice? Some people have had experience and they know probably about the same as I do, some of them. But some of them, they're like, well, hospice means I'm going to die, or my mom's going to die. I mean, in theory, yeah, but I would say, but we're all going to die.
Right.
Every one of us. But hospice is just an extra layer of support. I wish more people would sign on to it earlier to be able to benefit from all the disciplines. Sometimes people sign on and they just get to see me or one of the other nurses, and that's it. They don't get the aid, the volunteer, the music, all the stuff that you are entitled to it through your insurance. If you're on Medicare, you paid into Medicare for many years. That's part of your benefit, but you don't get it. So I wish people would sign on. It's a conversation I feel that a lot of doctors and specialists, a lot of oncologists need to maybe have a little bit sooner with the reality of things. But primary cares especially, I feel like really need to have those conversations. You know, what are your goals? If this is what's happening, what are your goals of care? Do you want to have to keep coming and seeing me every month? Do you want to keep getting your blood work done every month? Majority of these people are going to say no. I want to be home with my loved ones. So. Infection control, hand washing.
Everybody learned how to properly wash
Right,
their
in
hands during
kindergarten,
the
sing the
pandemic.
ABCs, lather them up. When you dry your hands off, please use the towel to open the bathroom door and then throw the hand towel out. Don't use cloth hand towels. So, at home we all have like hand towels. That's actually really gross. And they harbor bacteria. So paper towels, hand towels. Hepatitis B. So you guys shouldn't be coming into contact with any bloody or bodily fluid, but sometimes you go into facilities, they are clean, but there's always like that one-off. So hepatitis B vaccines, because the volunteers are offered it the same as employees are, correct? Is that okay?
Yes.
So hepatitis B is usually caused by, is caused by infected blood products, things like that. Main symptoms are mild pain, jaundice, but if it progresses far enough, it can cause cirrhosis and severe liver damage. So, you guys just graduated college, or so you're probably pretty vaccinated. I think that's still a requirement. Most of us, I think, got Hep B vaccines, or if you had children, you had to get it checked and had a titer. So I think they get a form, right, to
Yes.
approve
So
or-
I did have a follow-up call, just to make sure I understood what the current
they changed.
position is.
Yeah.
It is true that the younger the volunteers are, the more likelihood that you've already had your hepatitis B vaccine. But if you are not sure, if you have any sort of natural immunity to it, you can go to your doctor and ask them to do a titer. To
Titer.
see if you are still
If you titer against it.
if you still have immunity against it, and then you could determine whether you are in need of this vaccine or not. You're not required to get the vaccine, and I would agree that your risk for contact with hepatitis is very, very low in terms of your work as volunteers, even if you are going into healthcare settings. However, we offer the vaccine to all of our employees, and therefore you are considered our employees and you are eligible to get the vaccine. So there is a form in your books where you would either consent to getting it or decline it because you know you don't need it. And so you don't have to fill it out tonight, but I will collect it at the end of the next session so that I can have on hand whether you want me to forward your consent to our nurse educator, and she would schedule that for you. I think it's
Anybody who has
Like
an
from our doctor.
no, it's really, do you want to get the vaccine or do you not want to get the vaccine because you know that either you don't want it or you don't need it?
anybody who has an allergy to yeast or yeast products cannot get the hepatitis B vaccine.
I
Okay.
think it's in there.
No. Does it
Yeah,
say
Oh, is
that?
it in there?
Yeah.
Okay. Because I don't think it was in there before. So
I just, yeah, anyone who has an allergy to yeast or yeast products.
There we go. We're very thorough.
look at that.
It's given in 3 doses.
Yes.
And also, what I have heard from our agency is you can also get this vaccine from your primary care doctor, and they have it's much easier for them to keep track of the scheduling of it. So you could either get it through your own doctor, or if you want to have it done by our over across the street at the Jewish Healthcare Center, they can do it also.
Yeah, because they have to be done in certain intervals.
Yeah.
Yeah, that's it.
Okay.
That's all I have.
So I do want to say too, just to piggyback on what's already been said, the volunteers, you guys are a really pivotal piece of our team. We really, our patients definitely benefit from the companionship, all the things, all the company, the things, the activities that you can do. I think you make all of our volunteers, past, present, and future, make a really big impact. So thank you for your willingness to do this. And I'm actually very happy to hear that there's some aspiring doctors in the room, because I think that educating the medical team, especially doctors in the hospitals or private practice, it takes a lot to educate people what hospice really is all about, and to get rid of some of the stigma about hospice and just help people understand what hospice really looks like and how beneficial it can be for our patients and families. So I think that's really great. Hopefully what you learned today you can pass on. One thing I don't want to forget about too is the blue book in your packet. That's something that we do hand out to families on admission and also as needed. It's a very emotional read for families, but we advise them to read it because it talks about what the dying process looks like. So when they're witnessing certain changes in people's bodies and their loved ones' bodies, that they know that it's a natural part of disease progression. So what they're seeing is normal. It can be scary. It doesn't make it any easier to witness what's going on, but it just kind of helps them throughout that journey, if you will, and kind of just to understand what they're seeing. So we'll often refer during admission and then kind of re-refer back to families, to reread it. We always say don't read it before bed because it is very emotional. Read it with a loved one, read it in small parts. And oftentimes when we're interacting with patients, they're already experiencing some of these changes, so it kind of helps families validate that they've made the right decision for signing on to hospice. That's just one thing I just didn't want to forget to mention. I think that, again, your role is super important. It can be very emotional sitting with people towards end of life as they're talking about their experiences. You're doing a lot of life review. You're talking about their stories, experiences, relationships. It can be very emotional. There's also, to be mindful. It talks about boundaries in here, and I think what the real important takeaway is that there can be a lot of transference and countertransference. For those who don't know what that means, it can mean that you can take it, from a loved one you've lost, right? If they're talking about certain experiences, you can feel like, right, that feels like home. It feels a little too close to home for me, and you kind of start feeling yourself and how you respond, and to be mindful of that. The way they're interpreting and putting things on you, they may have something from their past. You remind them of that person or another experience. So to be mindful of that, and certainly, if it doesn't feel comfortable, to talk with Sue to bring it back. And talk to one of the social workers. Again, I said there's 4 of us that are out in the field. Maggie is an intake. She's also a social worker, and she's amazing too. But our core group that's in the field, our role is really to provide the psychosocial support Wendy kind of touched on too. We're supporting patients, but also families. We work with the patients one-on-one. If they're able to participate, we're doing a life review. We're talking about their feelings, thoughts, anxieties, things that are related to their life closure, and as they're facing their own mortality. Ray is the chaplain. He does similar things too, about just talking to people about what that might look like. What are some unresolved conflicts? What are things that are left unresolved? Is there guilt there? Same with families, they're going through the same journey as well, and they're part of the care team, so including them as much as possible. So we're assessing mood symptoms. So you'll also see in here, if you're visiting with a patient and the person says, you know what, I wish I were dead. Well, that's a red flag. You really want to hone in on that. That's something that you would have to notify. If you're in a facility, you would want to notify the nurse that's on on the unit right away, and you would want to notify the hospice team. So whether you call, I think it would just be calling the main number at that point, just in case it's after hours or whatever, but you would be calling the main number, you would be notifying the facility. If it's a home patient, if the family's there, let the family know. And again, just whatever you do, just call us right away. It would trigger an assessment, so the on-call nurse would go out and complete this questionnaire. It just means whether they're high risk or not, if they have an action plan to hurt themselves. That's something we take very, very seriously. We don't expect you to do anything as far as an assessment, get into questions, but obviously don't leave the patient unless they're safe. And that's why you alert, a facility member or a family member if the person's alone. Again, maybe make that phone call to the hospice team right away, just so the person's not left alone. Doesn't happen often, but as you do hear about, older adults especially, suicide risk is very, very high. And we don't just work with older adults. We don't work with pediatrics, but it's all adults. So I think the youngest we've had has been in their 30s, I think. It's very rare. We don't have a ton. So the majority are older, but it doesn't take away the fact that they have a history of trauma that we're assessing for as social workers. Not you guys, but in our assessments, we're always looking to see what might be triggering. We don't want to re-traumatize somebody who has a significant past. We ask about veterans and their experience, if they faced combat, what that looked like, what was the experience like for them. Ways we can intervene just to set up interventions to give them more support and to keep them safe. Again, everyone deserves a good death, whatever that looks like. And a lot of that is looking back, reflecting back on past experiences. We're not going to resolve anything at this point, but it's helping them cope with the things that they've experienced in their lifetime and how that relates to their end of life and that closure that they're facing. We work a lot with our team. For admissions, we'll go to, it's usually the nurse and the social worker that go out and do admissions, and we're providing a lot of education about hospice philosophy, what services we offer, how we can be supportive. We often ask about children in the family because we do legacy building projects. So there's a flyer in here that, we might work with grandkids to do fingerprinting, not even with grandkids, but sometimes patients want to, all the time, you want to honor anybody's legacy, right? Everybody has tradition in some way, and we want to support the family in making sure that they honor that person long after they're gone. So sometimes we'll do fingerprinting, and we make shapes with the fingerprints. We'll get creative. You can make keychains with the fingerprinting. Hospice volunteers have been really wonderful in helping out with some of these projects. Sometimes legacy building can be in the way of just experiences, maybe not legacy building, but experiences like, we take a patient swimming once in a while, and that's not necessarily legacy building, but it's part of our team that we do. We make recipe books. We've done, we've done a lot of different things. There's been, is what? Christmas in July, yep. We do letters with people. I've done with kids. Unfortunately, there was a younger man who had very young kids, and I made, the kids and I made a pillowcase for him with markers and stuff, and they got to draw all over it, and Dad got to use that as a pillow for his remaining days, and that was really special and a way for them to connect. We do memory boxes. You could think of all these things, and as volunteers, I'm sure you have a ton of creative ideas that you could think, and you can also do with these patients when you're spending time with them. You're really getting to know who they are. And again, if it feels like, if you're at somebody's home and you feel like there might be like more expectations of you to do things that you don't feel like is in your description as a volunteer, I would encourage you to bring it up with Sue. Sue will tell you what, things you shouldn't be doing, maybe should be doing as a volunteer. And that can look very different depending on the patient and where they're located. But to set those boundaries too, like you're not meant to be there like washing dishes and doing laundry and walking their dog or anything like that. But if you're there to give companionship while a loved one runs to the grocery store, or the loved one just needs to get out and go for a walk because they're burning out and they just need a break. That's what a lot of our team will suggest, go out and go for a walk, and we'll spend time with the patient one-on-one. And sometimes our patients will share things that they wouldn't normally share with a loved one there. So it's a good opportunity to really get to know the people, who they are, and I think that's the great honor of a hospice role in any role. Nurse, social work, volunteer, massage therapist, there is a true honor in spending time with somebody and really getting to know who they are as a person, because everybody has a story and not everybody gets to share that. And so you all being part of that team can really help draw that out of somebody. And again, it can be very emotional. So just to be mindful of your own self-care when you leave someone's home and it feels really heavy, it may. So just knowing that you have an outlet, whether it's calling one of us to process what you've just talked about, calling Sue, whatever your outlet looks like, it can be really taxing. It can be a lot. So just to be mindful of that for yourselves. We are part of We Honor Veterans program, so not only do we ask people about their volunteer experience because it's very important, but we also find ways to honor them. And what that looks like is, if we have time to plan it, sometimes we're in crisis. Somebody's actively dying, and we want to do a pinning ceremony right away. That does happen, but usually if we're able to find out somebody's veteran history. We find out, what era they were a part of, what branch of service, what their experience was like, but then we offer a ceremony. And the ceremony consists of reading a poem by either a family member or by a hospice staff member. There is another part that the hospice staff member does read for, during the ceremony. And then we we give out a pin, and usually the pin is somebody does the honor of pinning that person, whether it's a former veteran that they were with, or a close friend or a family member. So they pin, and that's a way to honor them. And then there's people, other people who speak. We invite like the whole hospice team, whoever can be there. It's a really beautiful experience. It's a way to honor somebody. We did one very early on, and the wife brought in like the flag from Afghanistan, and there was the patient's former barber, or actually he was still his barber, came in and cut his hair, every couple of weeks, and he was also a veteran, and he came in and the patient wanted him to pin him, and it was a really, really beautiful experience. We want it to be original for that person, individualized, but it's a really special way to honor that person. So we'd love for you to be part of that as well. Other than that, I'm trying to think of what else I can talk about for what we do. I think when you're interacting with people who have dementia, that's something I can touch on because it's in here. Reintroducing yourself every time. I don't know how many people have worked with people with dementia, but you may have to introduce yourself multiple times. Sometimes those patients get agitated, and sometimes finding ways to redirect them, or if they're very confused, they may be. But to be respectful and be mindful that they're not trying to give you a hard time, they're actually having a really hard time. And so you being there to comfort them is incredibly important. If getting to know what they did for work history, it's a great way to interact with them in general, whether they have dementia or not. If they were a teacher, finding ways to give them tasks as they were a teacher, because often with dementia, they'll revert back to their earlier days and feel like they have to get to work. Or some patients we have were seamstress. Anne Marie and I had a seamstress, and we gave her I think at some point they had given her fake scissors and like a big,
The plastic, the little kids sewing kit. I got her little kid's sewing kit.
Yeah.
And
she would just manipulate it, and it just kept her busy. But then you can talk to her about that. So you get really creative in finding ways to meaningfully interact with people. So whether they have dementia or not, there's really great ways to make that person feel really important, and I think that's also really just something to expect and a really positive experience for that person. And of course, if they're getting really agitated and you're getting uncomfortable, if they're at the facility or something, pull in a nurse, pull in another staff member, just so you can have a little bit of support. So all the facilities we go to are pretty great about that. If they're having a hard time, you can bring them out. And just make sure you let a staff member know. Don't leave a person in distress or agitated and walk out and leave. You may get frustrated, and that's understandable. It's normal to feel that way, but just to let a staff member know, help them, so they know to, help calm them down, whatever that might look like. But there's lots of ways to interact with folks who have dementia. And actually, I thought this was in here. So there's a little handbook, a little kind of tidbit on how to have creative activities. People who like cars, showing them magazines, ways to kind of defer and distract them, things like that. Just ways to intervene with them, or to interact with them. I do love the gardener one. I did actually sit with somebody and planted seeds. They were a gardener, and so I had a little busy bucket sort of thing, and she was able to put seeds. It was a kind of a messy disaster, but for her, she thought she was gardening. It was amazing. She thought she was right back at home in her garden. So artists, we have a volunteer who paints with one of our patients, and she does a beautiful job. He looks forward to it. Even just, holding the brush and making whatever kind of designs, those are things, just, again, meaningful ways to interact with people. People who really, really loved reading and either can't read anymore because of eyesight. We have volunteers and even social workers. We read to patients, or we connect them with the library to do audiobooks if they can't read but they can hear really well. But you're right, living with dignity, giving them respect, and helping them identify areas of their life where they can maintain control. And that's part of our role too, is helping them to be as independent as possible safely, and what does that look like, and how can we help give them the best quality, because at this point of their life, in their final stages, it's not quantity, it's about what's the best quality, how can we optimize their overall well-being, their comfort, well-being, what does that look like? And again, assessing mood status, and because depression in older adults, and especially facing mortality, their own mortality is it's quite significant, and it doesn't always have to be like with psychotropic interventions. It can be other supportive interventions, and sometimes just having the companionship and company, like you all, to spend time with them and treat them well, and do these things with them that are really meaningful is very impactful. So again, thank you for volunteering and being part of our team.
So after getting the bigger picture of what a patient and a family are going through, you can only imagine the mental, emotional, and spiritual place they're in. And so what's unique about the chaplain and the volunteer is we get to see a side of the patient that the medical staff doesn't get to see. So oftentimes, and don't take for granted your presence, but your presence is extremely important. You get the unique position of hearing what the patient or the family is going through, and they tend to go, and this is what's happening. This is what I feel. This is what I feel. So oftentimes you will experience somebody who is unloading their grief, unloading all of their internal pain. And they don't want to do it because they're saying, this medical team is here to care for me. They don't want to hear me. And I hear that a lot. They don't want to hear me, but I know you will listen. And that's one of the things that we're going to do together. Active listening. And what you're doing in your role is to listen to what they're doing or what they're feeling on the inside. So you're going to start digging below the surface and saying, why do you feel that way? And you're getting to know them. And oftentimes, I've heard this many, many times since I've been here, you know what? You're the first person I've ever told this to. And so they are able to unload the burdens that they've been carrying. Oftentimes they hear grief. When it comes to that realm, you don't have to console them. All they want is to be heard. You don't have to reach out and say, it's okay. It's not okay. It is not okay for them. And you are there to make sure you affirm what they're feeling. So as a chaplain, my job is multifold. When I do an assessment, I find out where are they spiritually? Are they in a crisis, existential crisis? What is their faith background? How does their faith, what does their faith look like in a situation like this, both for the patients and for the family? Because they're experiencing death or the coming death a different way. Not only are the families losing their loved ones, but the loved ones are concerned about leaving somebody behind. And so oftentimes as you'll see this more often, we get the privilege of letting them unload where their heart really is. And you are touching their heart by listening. So this is a very important role. We've had some volunteers say, oh my gosh, this person just said they're ready to go. They're ready to leave the earth. What I do is I come in and I ask a difficult question. Why do you want to leave the earth? So that's my job. My role is to find out where is the spiritual pain behind what they said. And oftentimes it's, I'm just scared of leaving my loved ones behind. I know where I'm going. I know where I'm headed. And so I'm comfortable and I'm at peace with that. It's who am I leaving behind? And it is until we explore that together, they go, oh, I should probably talk to my daughter. And I say, if that's what you believe you should do, then I encourage that. And then all of a sudden it opens up a conversation between the two, and then suddenly they have a good death. So that's my function as a chaplain, to find out what pain are you carrying mentally, emotionally, spiritually. And because we take a holistic approach, not only the body, but it's the mind and the soul as well. And so as a chaplain, I find out, what is your faith background? Do you have any rituals that bring you comfort and peace? There are some Roman Catholics who say, I love communion. I absolutely love communion. It brings me the best peace. Then I arrange either a priest to come in or a Eucharistic minister, or sometimes I do it. I'm non-denominational, and we take a non-religious approach to their spiritual care. Although I do have a master's degree in theology, I understand where they're coming from. So if they're of a different faith, as a matter of fact, I connected with a Jewish person, and I'm Christian, and we had the best conversation you could ever imagine. And he was like, I like you, why don't you come back? That was comforting for him, to know that I understood what he was saying and I appreciated where he was coming from. So you're in that unique space as well. Now, you don't have to talk theology. You don't have to do any of that. That's my role. But if they ask for you to pray, it's up to you. If you feel comfortable to pray, you can. But as a chaplain, I find out, okay, what is your faith background? So I can make the distinction between Pentecostal, the Baptist, the Catholic, how they pray and how they do it. And then so I approach from their foundation to pray the way they feel more comfortable. And so that's what I do as a chaplain. And just so that you know, eating chocolate cake is a very spiritual thing for them, could be. You'd be surprised. It could be very spiritual. I've seen a patient who said, you know what I like to do to bring to have a connection to my divine? I said, I'm very curious. What is it? I like to look out that window. I said, let's go. And we walk out, and she actually rolled herself to the window, and we sat together in silence. Don't underestimate presence. Don't underestimate presence. We sat, looked out the window, and we just very quietly said, do you feel that? She said that to me. Do you feel that? I said, yeah, I feel it. And we watched the birds. We looked at the trees. That was her way to connect to her divine. And I'll give you a personal experience. My daughter, when she was at her worst, she said, Dad, I don't want you and Mom to come in the room and say this and try to comfort me. I just want you to sit with me. And keep that in mind when you're sitting with a lot of these patients and family members. They're going to start talking about things to you that they wouldn't tell other medical staff.
What if they confess a murder?
That is a situation where you're going to have to...
What if they confess a murder?
I'll tell you this.
My mind just goes to these places.
Yeah.
I can't help
Okay, you might be somebody I want to hang out with, I think.
Eat cake and talk about dark stuff.
Yeah, well, I'll tell you this. Because I'm a veteran and I work with veterans, in the military, we have full confidentiality. We don't have to say anything to anybody, even the government. They can't bring us to court. But outside of that realm, if we were in the VA, we are mandatory reporters.
So you're gonna have to tell Susan.
So in this particular case, if they say I confessed, you are a mandatory reporter. I'm a mandatory reporter. It has to be told, especially if there is something like elder abuse or if there was child abuse. I'm a mandatory reporter. However, I have a high level of confidentiality. So the moment I walk out of that room, you're not going to hear about a patient unless it has something to do with IDT. And an example, I was working with a veteran, and as soon as, because I've worked with people who had PTSD, and as soon as I picked up on it, that if you tell him thank you for your service, it triggers him. And so I had to let the team here know, yes, he's a veteran, but don't say thank you for your service, because it will trigger him. And so that gives the team enough information to say, okay, I understand. A lot of times you're going to see a lot of grief. And so when they're trying to get the right medications here, they're like, I don't understand. She keeps crying. She keeps crying. Well, let me tell you the reason why. Because this is what's happening in her life. There's some grief that's happening there, and then the team can make the adjustments. So, but going all the way back, if somebody confesses, you're a mandatory reporter.
And that's to Susan, and then Susan will.
Yeah.
I'll just share with my team. On my pay grade to have to know what to do about it. And I would just say that that's exactly like, oftentimes with volunteers, right? You are trained for the work that you're going to do, but you may encounter things that really aren't what you're prepared to do. The only thing that you have to remember is there is a first call number, that if you ever feel like you are out of your comfort and you're not sure, you call this first call number and you get directed 24 hours a day, 7 days a week, no matter when you make your visit. You're always going to be connected with our team, somebody from our team, who will be the person who knows what to do with that information, right? So
Because we have had, as recent as, we have had some issues before, where, they have immediately called the number, and we've had to,
You go right there, or?
oh yeah, we've had some issues, and it's been great because the volunteer has recognized it, immediately reported it to the nurse's station, and immediately called our number. It was at 7 o'clock on Friday night,
Oh, wow.
and we're all hands on deck.
And if it's a patient in the facility, it could be just the case managing nurse calling the facility and saying, hey, just got word, what are you seeing? I can come out and make a visit right now so I can assess, or you let me know, right? And so they have protocols in all of these skilled nursing facilities that, let's just say, the example of you go to make your visit and the patient you're visiting says that an aide was very rough with her and her arm is hurting, right? Okay, as a volunteer, you don't know if that person is a reliable narrator or not. You might have noticed other tall tales that you've heard in your weekly visits, but it's a mandated reported kind of thing. You must report it to the facility saying, I don't know if this is true or not, but I was with my patient, Mary Smith, and she said this. They are required to follow up on it. Yeah. And they are required to do sort of an assessment. Does the patient have a bruise on her arm? Is there a skin tear that was caused by who knows what? She might have whacked her arm,
Or just made it up.
And again, it's not for you to figure it out, but it is for you to report it so that those in charge of figuring these things out know what they need to do. And every agency has its own protocols for dealing with these kinds of things.
Yeah, and before you go into a visit too, you also know that there's something happening. Like, for example, if I'm already processing grief with somebody, I will let the whole team know that she's grief processing right now. She's going to be very emotional for a couple of days. So if you come in, be aware that she's already processing that.
And we will be privy to all of that information.
Yeah. The other thing that we do as well is memorial services as well. We can do funeral, but typically what happens is the people who are coming in, they tend to have their own priests that do their funerals and so forth. But I don't think it's going to happen very often here with me because a lot of people are already connected. And so what I do is I make sure their spiritual guide or their spiritual connection or community is following along with what's happening. We do have, often we have a request for Bibles, rosary beads. We do have some rosary beads. A lot of people like the tactile feel of the rosary beads, and that brings them some spiritual comfort as well. And then so we do have other activities that we do. One of the ones that, like I said, your presence is important. I had a patient today who loves listening to country music. I know exactly who he likes because you're going to ask that question. Who is it you like? And we listened to some YouTube together, and he just went, "Oh, thank you," and he just went to sleep. So just be aware that that's the role. You're very much like a chaplain in this particular case.
Hi, I'm Laurel Hemmer, and I'm the bereavement counselor at JHC Hospice. Thanks for volunteering to come on board and help visit some of our patients. I just wanted to tell you a little bit about what the bereavement program is. Part of hospice is providing bereavement services to the families and loved ones, and we do that for 13 months after one of our patients dies. So it's my job to reach out to the family to see how everyone is doing, and the social workers will identify somebody in the family for me to contact. So we send mailings throughout the 13 months, and I also make regular phone calls throughout the 13 months. And we just see how they're doing. We offer grief education, we offer support, compassion, validate their feelings. And if they need further services, we can always offer to meet with them one-on-one. I can also refer them out for counseling or for groups. Speaking of groups, we do offer 2 bereavement support groups at hospice once a month. One is during the day and one is during the evening. And we have a lot of people attend them and really find them beneficial. Sometimes we will ask for volunteers to help with the bereavement program. We have someone that helps with all the mailings, and they do other administrative tasks for us. And then there are times where a spouse dies, and the spouse that is still living is really missing them and very alone. And so we have had volunteers provide companionship visits to them. They can help with their grief, but really they're just there to talk to them and support them. And once a year, we do have a memorial service over at JHCC, which hospice is very involved with. And we also partner with other assisted living programs in the area that we have patients at and help them with memorial services at their location at different times throughout the year. I think in general, that is what we do. And if you have any questions, I'm sure Susan can answer them for you. Thanks.
Hi, I'm Sarah Casati. I am the music therapist with JHC Hospice. I'm going to talk to you today a little bit about my role here as the music therapist. So, start off by telling you a little about what music therapy is and what we do. So music therapy is the use of music as a therapeutic tool to work towards non-musical goals. So even though music is at the core of all of my visits, I'm working on other things, whether it's fostering family connection, alleviating symptoms of depression or anxiety, encouraging participation and engagement from patients. And this can look very different depending on each individual patient and their current situation. I usually bring my guitar into visits. I do a lot of singing, and patients will participate however it is that they are able. If they want to sit back and listen to music, that is perfectly fine. I encourage patients to sing, to move to music, to engage in conversation. It's however they feel comfortable engaging at that particular time. So music therapy is offered at admission. Patients can decide if they would like to receive music therapy services or not. If they do, then I will contact them, schedule visits, and start going out and seeing patients. Most of them I see once per month. So little bit about the qualifications to become a music therapist. So music therapy is its own degree program. It is bachelor level entry, so music therapists do need to get a bachelor's degree at minimum, and there are several schools you can go to get that. We need to do clinical practicum hours, internship, and then sit for a board certification exam at the end of all of this. And that is a certification that, like all the other professions, I do have to maintain every 5 years to stay current with my licensure. So I still encourage volunteers if they would like to use music in their visits. I greatly encourage that. And there's a variety of ways that you can do that. You can bring pre-recorded music into visits and engage with the patient. If you play an instrument or you sing, I greatly encourage people to bring those instruments and to use them with patients.
You've talked before about how you moderate your visits based on the mood or situation of the patient.
So one of the things that I like to do in my visit, and one of the reasons why I love using live music, if at all possible, is because when I play a song that's pre-recorded, no matter how many times you play it, it's going to sound exactly the same. The recording does not change. So one of the beautiful things about using live music in visits is that depending on how that patient is presenting on any given day, I can change how I'm going to sing that song. So a song like Que Sera Sera, if that patient is in a great mood, they're feeling fantastic, it's upbeat, then we're going to sing it. When I was just a little girl, I asked my mother, what will I be? And if I go in and a patient is maybe feeling a little bit down that day, they're not quite as upbeat, we don't have to sing it up in the rafters like that. We can sing it much quieter, more lullaby style. When I was just a little girl, I asked my mother, what will I be? So visits are definitely tailored to however that patient is presenting on that given day, which is a really great way to keep them engaged.
Do you ever get involved for vigil visits when a patient is truly at the very, very end? Do families typically request the music therapist to come when a patient is transitioning to end of life?
Okay. So it does happen that depending on my rapport and my relationship and the family themselves, I will get requested to be present at bedside when a patient is transitioning, when they're actively passing. And so if they request it and I'm able to be there as a part of that process, then I will make every effort to be there with them. Visits when a patient is transitioning look a little bit different. It's more calming, relaxing music. If family members are present, then it can be a little bit of a tense situation for everyone. So I'm using music to try to calm everyone down, keep family members engaged, encourage them to, talk, share stories, share those final moments with their loved one. And if it's at all appropriate for us to be singing, then that's what we do. If it's just me, myself there, then I will play some quiet music and just kind of see however that patient is reacting and responding at that time.